Endoscopic ultrasound-guided gastroenterostomy in a patient with neoplastic pyloric stenosis. Case study: 55-year-old male with history of locally advanced pancreatic cancer with pyloric stenosis. He has history of obstructive jaundice treated with endoscopic ultrasound-guided hepaticogastrostomy. Now presented with repeated vomiting. What to do? EUS guided gastroenterostomy or endoscopic stenting. This is a meta-analysis and systemic review comparing endoscopic ultrasound-guided gastroenterostomy versus enteral stenting for gastric outlet obstruction. The pooled OR of 0.65 suggests that EUS-guided gastroenterostomy may have a lower technical success. However, it is not statistically significant. The pooled OLD ratio of 7.9 strongly indicates that endoscopic stenting is associated with a significantly higher risk of reintervention. This forest plot suggests there is no clear evidence that one method is safer in terms of adverse event. After discussion with the patient family, the plan is to perform gastroenterostomy with 2 cm by 1 cm hot axial stent. This is the endoscopic view of dilated jejunal loops filled with a huge amount of normal saline diluted with methylene blue. After insertion of a catheter which continuously irrigates a huge amount of normal saline. Then we put the hot axials and trying to pierce the gastric wall and duodenal wall by the hot axials stent itself. Then we open the distal flanges of the stent and pulling the stent towards the gastric wall in order to be ensured that the 1 cm length stent is completely opposed to the gastric wall. We still pushing the stent until one of the arm of the flange hitting the delivery system in order to be sure that there is complete oppositions of the stent to the gastric wall. At that time, we open the proximal flange inside the endoscopic channel to be sure that this flange open inside the gastric lumen, and we slightly pull the scope in order to see the stent. This is the endoscopic view showing the stent fully open inside the gastric lumen, and we actually put a guide wire in order to be sure that as a safe marker in case of emergency we can put another stent inside this stent. With excessive suctions we can see that the fluid can come through the stent to the gastric lumen. Key message: EUS guided gastroenterostomy and endoscopic stenting are comparable in terms of their technical effectiveness. However, EUS guided gastroenterostomy has improved clinical effectiveness and a lower reintervention rate and safety profile than endoscopic stenting for palliation of gastric outlet obstruction. EUS guided gastroenterostomy is the preferred method for treating gastric outlet obstruction in center with expertise.